Welcome everybody to Controversies in Stroke, Medical Management versus Stenting of Intracranial Stenosis. We heard a superb overview of this topic this morning from Dr. Mark Jimowitz, our keynote speaker. And now we will throw down the gauntlet, sharpen our knives, and introduce our two debaters. Arguing in favor of medical management for intracranial stenosis is Dr. Shyam Panchal. Dr. Panchal is a vascular neurologist at Houston Methodist The Woodlands. He graduated from UTMB Medical School, completed his neurology residency at Houston Methodist Hospital with distinction, I might add, serving as chief resident his final year, and went to Vanderbilt University for his vascular neurology fellowship before returning to Houston Methodist. Dr. Panchal, you have the floor.
Okay. Thank you, Dr. Chu. So I don't know how much of a gauntlet can be thrown down about this conversation here. Much more of a beating of a, in some ways, of a somewhat of a dead horse. Oh, okay, fine. Can everyone hear me?
Yes.
Okay, very good. All right, so my discussion here will be focusing on the superiority of medical management, but as Dr. Chimowitz had addressed earlier during this symposium, some of the things that I will be talking about, a lot of what I had been talking about here, there are a couple of things that I wanted to focus on in terms of what medical management is, and then address some of the detriments of surgical management before allowing Dr. Smith to take the converse. So let's kind of focus on what the tenets of aggressive medical management are. As the Sampras trial kind of had outlined this, we can kind of focus on how the trial was designed and some of the features of what aggressive medical management is, not necessarily focusing on all of it, but a couple of certain key features. So the way the trial was designed was to focus on a couple of different things in terms of primary and then secondary risk factor targets. And so primary risk factor targets were both blood pressure and cholesterol in terms of strict adherence to blood pressure with systolic blood pressure target less than 140, and then those with diabetes less than 130, and then adhering to and setting this LDL target of less than 70, and then followed by these secondary risk factor targets of addressing the non-HDLs, the A1C for diabetic patients, and then something that we will touch on later is weight management as well as physical activity to encapsulate this aggressive component of risk factor management, as we can all kind of address to and acknowledge when we talk about medical management. We tend to pigeonhole into antithrombotics, diabetics, blood pressure, and cholesterol, but we have to keep the whole picture in mind, and we will focus on why that's important. And so weight management in these patients was addressed to what a patient's BMI was and the reduction based upon their weight class, as well as physical activity managed by this certain score that the trial had used in terms of physical activity, how moderate or intensive someone's physical activity was in terms of their daily activity and the level of that. So addressing lipid-lowering therapy, we are familiar with these trials and our use of them in the management of our stroke patients. And so just to reiterate which ones these were, the Sparkle trial addressing the superiority of the high-dose or high-intensity statins with respect to high-dose atorvastatin compared to placebo in secondary stroke prevention, demonstrating a trend, at least in the specific population of these, bringing it back to the intracranial athero, a trend at least towards reduction in the large artery athero patients, with the background of the demonstrated reduction in overall cardiovascular risk. Sampras itself had used rosuvastatin up to 20 milligrams in patients with the LDL greater than 70. Going ahead beyond just the statin class medications, there was a Fourier trial with Repatha, with one of our sponsors here as well, demonstrating both not only the significance of the reduction in the LDL target itself, but also the reduction in the overall cardiovascular and cerebrovascular risk, including the stroke risk reduction as well. It was a bit difficult to find as to whether or not the subtype of stroke in these patients was addressed to large artery atherosclerosis, but at least the overall population subset of stroke patients demonstrated risk reduction as well. So addressing the lipids was important and a central tenet to this aggressive medical management, as we very well know. Diabetes management, in terms of talking and addressing something that is a bit more new and relevant to how we were managing these patients and bringing bringing diabetes under better control and reducing the risk of stroke, something that we have worked towards changing guidelines and addressing in guidelines and really sort of seeing an impact is these newer classes of anti-diabetic agents, the DPP-4s, the GLP-1s, and SGLT2 inhibitors. The trials respective to these patients, there was a Cochrane database that was done recently about 2 years ago that demonstrated these different classes of newer anti-diabetics. The DPP-4s did not demonstrate risk reduction in cerebrovascular or cardiovascular mortality or reduction in stroke. However, in the GLP-1s and the SGLT2 inhibitors, there was a statistically significant reduction in the risk of overall cerebral cardiovascular risk and mortality, as well as a stroke risk reduction. And so there are more advanced and more newer ways for which being more aggressive with the tenet of diabetes has led to a reduction in stroke overall, even since the time of Sampras. Bringing this back to the non-pharmacological and outside the box of just medication treatment, I kind of wanted to bring to forth the lifestyle modification that was one feature of the Sampras trial, and what we mean when we say medical management and aggressive medical management is addressing the weight management and the physical activity of these patients. And so this was a different analysis of the Sampras trial, looking at how well someone adhered to the weight management and the physical activity among other primary and secondary risk factors. And something to bring to light here is that only 19 patients overall, or 19% of patients overall, achieved their target in terms of weight management by risk reduction of their BMI, and only 44% of patients actually met the level of physical activity that was intended to be required as part of this aggressive medical management feature. And what that translated to in patients that actually had a risk or actually ended up having the primary endpoint of stroke, MI, or some sort of vascular death at 3 years, something to highlight here is that physical activity up to 5 times the number of patients that suffered one of these endpoints were out of target in terms of where their physical activity should have been. And those patients or those members in this trial who actually demonstrated a more aggressive level of physical activity had a more meaningful reduction compared to the other risk factors, either primary or secondary, in terms of reducing the risk of stroke. So this just highlights in terms of the level of importance of physical activity and what it meant to the long-term achievement of reducing the risk of stroke in this trial, how it's not just addressing not even the primary risk factor targets of LDL and blood pressure, but physical activity really had a significant impact in terms of the stroke risk reduction here. It would be wrong to address medical management and the superiority of medical management without addressing medical or the antithrombotics. This is maybe had been addressed earlier to some component in ad nauseum, and so just to kind of bring forth the trials that are relevant to this in sort of a sequential manner. Wassid initially comparing aspirin to Coumadin had no benefit compared to the Coumadin over aspirin without a significantly increased risk of adverse events, including hemorrhage. And so at least moving and shying away from anticoagulation initially, not to say that that is something that should not be focused on now, but then coming forth to Sampras with the dual antiplatelets, with aspirin and Plavix, demonstrating superiority over the stenting arm. And then going into that, a little bit more detailed here, when addressing antithrombotic therapy, there have been other trials addressing different forms of antithrombotics and even just duration of antiplatelet therapy beyond just the 3 months for which Sampras had outlined. And so going back to Match in 2014, Charisma in 2004 and 2006 respectively, and then in SPS3.com in 2012, looking at different stroke populations, not necessarily intracranial athero patients, but all-cause or high-risk patients overall, looking at beyond this 3-month time frame and just looking at the duration here, the outcome in terms of stroke risk reduction was not necessarily more significant the longer that you use antiplatelets, or at least the aspirin Plavix class, without suffering a higher hemorrhage risk. And so, bringing this to real world, we keep patients there, at least when we're in the hospital and seeing patients, we plan for 3 months of aspirin and Plavix, but it's not necessarily the case that all these patients are always taken off after that 3-month time of the Plavix. And so really kind of highlighting that the duration of dual antiplatelet with respect to aspirin and Plavix still needs to be clarified. But looking at other antiplatelet agents, Thales had recently come out in the last couple of years looking at aspirin and ticagrelor over a 30-day time frame compared to aspirin alone. Excuse me. In terms of the stroke outcome risk, there was a risk reduction within 30 days. However, these patients who were on the aspirin and ticagrelor arm did suffer a higher hemorrhage risk compared to just monotherapy. And so while there was some degree of benefit with a different agent here, the risk is not necessarily equally beneficial. Going ahead here, Compass, I believe, was addressed earlier as well in Dr. Chimowitz's presentation, but looking beyond just in terms of what antithrombotics we can choose from, antiplatelet plus anticoagulation in some form or another is something that warrants more discussion in terms of being aggressive with antithrombotics and medical therapy. And so in those patients with stable cardiovascular disease, the trial focused on Xarelto plus aspirin, aspirin alone versus rivaroxaban alone over a 23-month follow-up period, and demonstrated a degree of significance in terms of reduction in the primary outcome of deaths, or CV death, stroke, and non-fatal MI. There was some degree of higher hemorrhage in these patients with a combination, but looking ahead, this may be something that warrants more addressing in terms of how to be more aggressive with medical management beyond just looking at an antiplatelet class in terms of what antithrombotic regimen these patients can be on. I had more. Okay. Well, I had more here in terms of looking at the detriments of surgical intervention. I will just kind of talk through them with Dr. Smith likely addressing the same thing that I will be talking about here. But it is not worth talking about the superiority of medical management without addressing the inferiority, or at least the detriments of surgical management, at least as to where they are now. And so the primary way to really look at this in sort of a meaningful way is to look at the long-term outcome of patients that were involved in the Sampras study. And so beyond just the 30-day endpoint, or at least primary endpoint of these patients, when these patients were looked out at the 1, 2, and 3-year mark in terms of their overall risk reduction, there maintained a significance in terms of the trend towards improvement with, or at least reduction in the primary outcome of stroke and MI and others, cardiovascular death, compared to those patients who underwent surgical intervention. And so the benefit of medical management in these patients was maintained beyond just the initial time frame, but well out to 3 years, without a sort of normalization or equivalence in terms of the benefit provided to those patients who underwent surgical intervention. There are other trials that have come out somewhat recently, including Weave and Woven, who I think Dr. Smith will touch base upon in some manner or another, but it remains the case that medical management, at least in terms of the primary means of addressing these patients with intracranial athero, remains the superiority, while there is work to be done to address what that aggressive medical management is in terms of cholesterol levels, diabetes management, as well as physical activity. The detriments of surgical intervention as a primary means of addressing and treating these patients has not yet been met anywhere near to what medical management is, save for emergent situations. And so that's kind of where things are without the rest of my slides and without running over on time.